sesión de neuroradiología durante este curso de resonancia magnética organizado por el CIR. Ya sé que muchos han preferido irse al mar, esa es una competencia difícil de ganarles, pero aquí tenemos una sesión que los que están presentes van a tener la gran fortuna de participar. Verdaderamente la facultad, los miembros del faculty que están aquí hoy día son excepcionales y estamos muy agradecidos a la Sociedad Europea de Radiología de habernos regalado con estos maestros de la neuroradiología. Igualmente quiero agradecer, por supuesto, y felicitar a Gloria Soto, la directora del curso, que como lo que hace Gloria, siempre lo hace bien. Entonces no tenemos más que mirar lo que está ocurriendo a nuestro alrededor y ver los nombres que han conseguido para que vengan a enseñarnos acá, es extraordinario. Entonces, voy a comenzar sin mucho más que decir, presentando al doctor Paul Parissel, que es uno de los profesores de la Sociedad Europea de Radiología. Ustedes ya lo han visto anteriormente, a mediodía hizo una presentación sobre la sociedad que él acaba de ser presidente y todas las ventajas que tenemos gracias a esa sociedad, incluyendo su participación hoy en esta sesión. Sin más que decir, les presento el título del doctor Parissel. No, ese no es el título. Es neuroimagen en pacientes con lesión cerebral traumática, una guía práctica. Entonces, con ustedes, el doctor Paul Parissel.
Muchas gracias, profesora Del Carpio. Muchas gracias a profesor Soto por su agradable invitación. Yo voy a hacer este curso en inglés porque mi español es muy malo. Vamos a comenzar. We are going to talk about neuroimaging in patients with traumatic brain injury. And I call this a practical guide. I would like to acknowledge my friends and co-workers from the University of Antwerp. You may know their names, and I am grateful for their support and their friendship in preparing this presentation. Now, I'm going to start first with a thought experiment. We have 6 different patients with a severe traumatic brain injury, lesión cerebral traumático. And they have a Glasgow Coma Scale of 6 out of 15. So when I tell you somebody has a Glasgow Coma Scale of 6 out of 15, what do you think? What do you imagine? What comes to your mind? Ok, severo, con hemorragia. ¿Dónde? ¿Intracerebral? ¿Intracerebral? ¿Solo intracerebral?
Podría haber un subdural, un hematoma.
Subdural, muy bien. ¿Otra cosa? Lesión axonal, muy bien. Vamos a ver. My first patient has an epidural hematoma. My second patient has an intracerebral contusion hematoma. My third patient has diffuse axonal injury with a petechial hemorrhage. My third patient has a massive subdural hematoma with mass effect with subarachnoid hemorrhage. My fifth patient has subarachnoid blood and intraventricular blood. And my sixth patient has diffuse cerebral edema. All of them have a Glasgow Coma Scale of 6 out of 15. These patients will go to the operating room. These patients will go to intensive care. This patient will probably need angiography to rule out an aneurysm. This patient probably also goes to the neurosurgery. So we have 6 completely different patients with different management who have the same Glasgow Coma Scale. So my first point here is that you should remember that the Glasgow Coma Scale cannot be used to guide patient management and cannot be used to predict outcome. And we should not forget that in neurotraumatology, we are the eyes of the neurosurgeon. And this is very important. So when we prepare this course, they are usually asking us for learning objectives. And this is the ECR style of writing learning objectives. And for all of us who have done this, it's always a little bit artificial. But this is the reality. This is the kind of patient who comes in to the trauma center with severe head lesion. And the question is, how do we deal with this? How will we actually start to think about this? So we are going to look, and I have defined 10 different points. And these 10 different points are, starting from the outside, the extracranial soft tissues. We will discuss fractures, epidural, subdural hematoma. We will discuss cerebral contusions. We will discuss diffuse axonal injury, secondary lesions, new MRI techniques, perfusion imaging, and long-term sequelae. This is what we are going to cover in the next 45 minutes. I have some interactive cases mixed in, so I will be asking for your feedback and your support on this. So let's start with the extracranial soft tissues, which is the least important thing to do. It has virtually no importance. But it is important because they tell you where the impact took place. And this is the coup site. And if we identify a lesion such as this on CT, what would you call this in your report? What is the name that you would use to report this? Extracranial, epicranial hematoma. Can you be more precise? Una fractura también. But when you look at this, what is this line here? This is skin, right? This is dermis, epidermis, yeah? And what is this dark line here? Subcutaneous fat. So this is actually below a structure. It is contained in a structure, and we call this the galea aponeurotica. And so we call this correctly, we call this a subgaleal hematoma, and we look on the bone windows for a fracture, okay? But it's important to identify because sometimes you can see a skin laceration in one point. And when we look at the CT scan, the reconstructed images, we can see the fracture, the extent of the fracture in the occiput, which is non-displaced. Now this is MR. On MR, we have this here. What would we call this? Contusión hemorrágica. So it's bright on T1. But let's focus on the outside of the skull. This is a very large collection on the outside, which is a subgaleal hematoma. And I invite you to look in detail in this part here. We're going to look and we're going to magnify this. Now, if we see here, we see the same information. We see the skin and the subcutaneous fat, which is bright on T1. Then we see the dark line, And this dark line is the gallia aponeurotica. And then we see deeper the os frontale, the frontal bone, with the tabula externa, the tabula interna, and the diploe. And the area in between there, all of that, is the subgaleal hematoma. So the point that I'm making is that you can be more precise. Instead of saying just an extracranial or an epicranial hematoma, you can actually locate this below the gallia aponeurotica, which is a very strong fibrous tissue plane. There is one other type of extracranial soft tissue lesion, which is the so-called cephalohematoma that we see in pediatrics mostly, which is limited to the surface of one bone, and it is in fact a subperiosteal hematoma. And the subperiosteal hematoma is the subperiosteal hematoma occurs between the periosteum and the bone, and it may calcify, as we see here, and here you see it on MR in the same patient. And this is sometimes called the extracranial equivalent of an epidural hematoma, because it is limited by the sutures. It does not cross suture lines. It is very, very limited. So when we look at an overview of scalp lesions, there's a number of less common types, but we covered here the subgaleal hematoma, which is the equivalent of an extracranial subdural, because it may spread over a very long distance. And then the cephalohematoma, which is the equivalent of an extracranial epidural hematoma, which is located between the periosteum and the bone and does not cross suture lines. So my first point here, my first key point is, even though it is not so important clinically, look for the bump on the head. This is what we tell our residents, because the bump on the head tells you where the impact took place and exactly where you will have to look for the coup lesion and the contra-coup lesion. Second issue is fractures. We all know fractures, right? And we are familiar with fractures, and we know that we have to look for this. Now, when we look at a patient such as this, what kind of traumatic lesions do you recognize in this kind of patient? So let's start with the bump on the head. And the bump on the head is here, right? This is a subgaleal hematoma. There is also, what is this? Epidural. And then always look at the ventricles. And when you see this, what is this? This is intraventricular hemorrhage. Yeah? So, and this is a young patient or an older patient? There is some atrophy, yeah? And when we look at the bone windows, we see that there is a fracture, a non-displaced fracture, but this fracture crosses a dark line in the diploe. And this diploe, this is, what is this dark structure in the bone? What is this? This is a vein. Un lago venoso intradiploico. And because of this fracture, which is crossing this venous lake, you get an epidural, which is venous in origin. Okay? With 3D, it's very easy to look at the extent of the fracture. And personally, I like very much these 3D applications because they give you a great idea. For example, look at this patient. What do you imagine with this kind of patient? You can almost see what is the cause here. This was a guy on a hockey field hockey, who received a ball with very high speed, and so there is a depression fracture with multiple fracture elements above the orbit. You can understand the mechanism of trauma from these 3D images. You know where to look for the injuries intracranially. And we like very much the multi-detector CT because in a few minutes it gives you a complete overview of all the lesions that you have in this man who was beaten with a baseball bat and who was actually dying shortly after the CT scan. You can see here all of the fractures. My second point is, my key point is, every fracture tells a story. And this is important because we live in a time where there is a lot of medico-legal litigation. You have to understand where is the impact, where is the fracture, and where the fracture is, from there you have to understand how the lesions occur intracranially. Third element, epidural hematoma. We all know this, right? We all know that an epidural hematoma is lens-shaped. We know this kind of image. It stops here. Why does it stop here? What is here? Sutura coronal. E aquí? The sutura lambdoidea. And you see the hematoma, and this is un hematoma epidural arterial. Oh, yeah. So this is the most typical appearance of an acute epidural hematoma, and typically associated with laceration of the middle meningeal artery. But what is less well known is that there is also another variant. There is a venous epidural hematoma, and we will discuss this in a second. There is another patient with an acute epidural hematoma, and you should be aware that the CT density increases as the hematoma matures. So you see a heterogeneous appearance of the hematoma, and you know that this is probably due to a laceration of the middle meningeal artery, which is somewhere here. And so the area of active bleeding is somewhat heterogeneously hypodense. And sometimes you may see something that the Americans call like almost like a spiral where the blood is coming, and this is known as the swirl sign, exactly. En español, swirl sign? Remolino. Remolino, como un molino. Claro. So, and as you move away from this, you see that the inner part of the hematoma is denser, and this is the blood clot. This is very clear. We know that this is an acutely bleeding arterial epidural hematoma. But this is the other variant. This is very different in behavior and very different in pattern. This is a venous epidural hematoma, and it lives in a typical location, which is here. It's the anterior part of the middle cranial fossa, and it's usually due to a fracture here or a laceration of the sphenoparietal sinus. And Dr. Alisa Jean from the San Francisco group reported this as a separate entity. It is a subgroup of traumatic epidural hematomas with a benign natural history. And if it is postulated that they arise from venous bleeding due to disruption of the sphenoparietal sinus and or bleeding from diploic veins due to a skull fracture. This is a benign lesion. This is a do not touch lesion. When you see this, sometimes you have a first year or a second year neurosurgery resident that wants to operate, but you should tell them, don't touch. You watch the patient, you do a repeat scan, 24 hours, 48 hours, and most of these lesions disappear spontaneously, completely disappear within 3 to 4 to 6 weeks. So it is a benign venous lesion. There is no increased intracranial hypertension. So here it is again, and here it is, very typical location. So my third key point is that epidural hematomas are usually arterial in the vast majority of cases, but there are some cases where they are resulting from venous bleeding, and this is up to 1/3 of patients, typically located in the middle cranial fossa. We move to subdural hematoma. You are all familiar with subdural hematoma. You know the anatomy, that the big draining veins that cover the surface of the brain run to, for example, the superior sagittal sinus. This is the dura mater, and the dura mater has been moved away in this specimen, and you see these veins going towards the superior sagittal sinus. As the brain becomes more atrophic, that is, as we are aging, as we are drinking more tequila and margarita, and we become more atrophic, these veins have a longer vulnerable course. And it means that subdural hematomas are typically associated with older people, and quite often there is a history of alcohol use or abuse. So the imaging findings, these lesions have a concave inward border, like a croissant. They may be very heterogeneous. And this is a 69-year-old man, and look at the amount of edema. They are usually associated with quite a lot of edema. Sometimes they may bleed in repeated episodes. And again, I show you here on CT, there is a layering phenomenon, and it indicates that this hematoma has bled and rebled in repeated episodes. And again, please notice the huge amount of edema. Now, in a case such as this, which is the more recent bleed? Is it on the inside? Is it on the outside? On CT? It's impossible to say. With MR, you can actually see this a little bit better, because here, for example, you see that the inside of this layer is dark on T2 and sort of iso-intense on T1, indicating deoxyhemoglobin, so this is more recent. And the outside of the subdural is bright on T2, hipersignal in T2, and hipersignal in T1, and this indicates extracellular methemoglobin in an older hematoma. Now, my fourth key point is that subdural hematomas, they may be acute, subacute, or chronic, and they have the highest mortality rate of all head injuries. And the reason is that, one, they occur in older people, two, they occur in people often with alcohol abuse, and three, and this is relatively new, is that they are associated with a huge amount of edema, and because for some reason these hematomas appear to release neurotoxic substances, neurotoxic transmitters in the brain that are causing huge amounts of edema. 5, cerebral contusions. You are all familiar with the old model of the coup and the contre-coup lesions. Now, if you tell your residents to report trauma cases, they should think in these terms. So I'm going to ask you a number of topics and ask you, where do these lesions occur? Okay, the subgaleal hematoma, where does it occur? On the coup side or the contre-coup side? The coup side. The fracture, the coup side. The epidural hematoma, the coup side. The subdural hematoma. Most often you will find that on the contre-coup side. The hemorrhagic contusion. Hemorrhagic contusion can actually be both. It can be on the coup side and on the contre-coup side, and the way you picture the brain is like a semi-viscous sphere, and if you push it on one side, there are pressure waves that reverberate in the brain, and that may actually cause standing waves on the opposite side, causing these contre-coup lesions. A few examples, and sometimes it is not so easy. 17-year-old man injured in a motor vehicle accident, and I show you some images. We start by looking for the subgaleal hematoma. There may be some swelling here, but there may be also some swelling on the other side. There is a subdural here, small. There is some edema. But then your eye catches, and I don't know if you can see this, there are two little black areas there. Can you see this? What is this? Aire. And when there is aire, there must be a fracture on that side. And then you start to look at the bone windows, and you see that there is a linear fracture that was also involving, not well seen on this reconstruction, the mastoid. So the air tells you where was the coup site. When you report this, mention this. Because if you don't, a lawyer will get your report, and you just don't say an inventory of all the lesions. You try to actually make sense of what there is, and you mention this. So cerebral contusions occur in typical locations, the base of the frontal lobes, the temporal lobes, you know that. Sometimes the midbrain, but very rarely infratentorially. Most of these lesions occur in vulnerable locations. The frontal lobes, because they are adjacent to the surface of the orbit, which is very irregular. The temporal lobes, because they take the deceleration trauma, and these are typical locations. Examples on CT: hemorrhagic contusion, right frontal; non-hemorrhagic contusion, right temporal. And what is this? Subdural. And please, there are many, I see always many residents who report this as like a subarachnoid hemorrhage layering against the tentorium. This is a subdural hemorrhage, and you can see that it stops at the falx and that it is along the tentorium, okay? On MR, these contusions, you can see them quite well. Typical contusions in the frontal lobe, hemorrhagic with extracellular methemoglobin, bright on T1, bright on T2. Yeah, and if you compare pathology specimen findings with MR images, you may see here that there is a brown color, a brown-red color, and this brown-red color signifies what? What is this? Be more specific, what stage of hematoma? What does the brown color mean? Hemosiderina, yeah. So it's hemosiderin, which is non-water soluble, and so you have to think when you see something, this is not the same patient, but when you see something like this, you have to think that there is hemosiderin in the brain and that you have to look for that. So we remember that cerebral contusions can occur on the coup site, and they can occur on the contra-coup site, both, and oftentimes they are bigger on the contra-coup site than on the coup site. Next is diffuse axonal injury. Diffuse axonal injury is something that I always found difficult to understand, but I have a little video that will help you to understand this. This is the mechanism of diffuse axonal injury. If you are inside, can you imagine the deceleration forces, the kinetic energy that is stored in your white matter? Of gray and white matter, which is what is called in English shearing injuries or diffuse axonal injury. Un caso. A man who is 32 years old, injured in a high-speed motor vehicle accident, upon arrival has a Glasgow coma scale of 3 out of 15. This is a deep coma, 3 out of 15. This is the CT scan. Any lesions on CT? I see some people saying no. But look carefully, what is this here? This is intraventricular blood. Always check for intraventricular blood. Always, always look for small amounts of intraventricular blood. And maybe there is some edema in this area. But the question is, does this explain a patient in a deep coma? There is a discrepancy between the CT scan and the neurologic status. So we go to MR and we do the MR the same day. And on MR, first of all, we see that there is some blood in the occipital horn. See it here. There is maybe some blood here in the right thalamus. There is some high signal intensity here in the splenium of the corpus callosum on flare. There is some blood here. There is blood in the occipital horn on the right. There is blood in the occipital horn on the left. There are some high signal intensity areas there. But the sequence that we need to do is diffusion. And on diffusion, we see cytotoxic edema. And on the SWI, we see blood. This is typical of diffuse axonal injury. And we know that CT scan seriously underestimates the extent of traumatic brain lesions in diffuse axonal injury. Here are two different patients, and they both were in motor vehicle accidents. Now, if you look at this case, there's a very subtle finding. Do you see it? Okay. There is a little point. This is a small petechial hemorrhage, and here it's a little bit easier to see. But this is the tip of the iceberg. There is much more going on there. So we like to do MR in patients with diffuse axonal injury, and we prefer to do the MR between the 2nd and the 5th day after the injury. And we do the diffusion-weighted images to look for cytotoxic edema. And we do the gradient echo or susceptibility-weighted images to look for blood degradation products. And this is a typical distribution, a peripheral distribution at the edge of the gray and the white matter, typical distribution, sometimes also involving the splenium of the corpus callosum. As in this patient, this is a 33-year-old woman with diffuse axonal injury involving here the splenium of the corpus callosum. And I show you the axial images here, low diffusion restriction, low signal on the ADC maps, high signal on the diffusion-weighted imaging maps. This is typical of diffuse axonal injury. These patients are in deep coma, and these patients often have a negative or nearly negative CT scan. Same patient, you see some other lesions with diffusion restriction in the right frontal, near the internal capsule, and you look at the ADC maps. And these are the gradient echo, long echo time showing the hemorrhage. Now, once hemosiderin gets in the brain, it stays there. Hemosiderina is a pigment, and the way that I compare it is like with a tattoo. If you go get a tattoo, the pigment is placed under your skin. And once it is under the skin, it is impossible for the body to remove it. This is the same with hemosiderin. But the skin is represented by the blood-brain barrier. And once the blood-brain barrier closes, the hemosiderin stays because macrophages, they are not able to get to this hemosiderin. And so the hemosiderin can stay for years and years and may cause epilepsy. This is a patient that was referred to us by a neurologist, a very good neurologist. And we had to do an MRI with the question, rule out mesial temporal sclerosis. And we did the MRI, we did a routine MRI, including gradient echoes. So we talked to the patient and we said, did you have an accident? And he said, yes, I had a motorcycle accident 4 months ago. The neurologist was not aware, because this is something that neurologists usually do not think about. They think about, mesial temporal sclerosis or a tumor or whatever. And in my experience, sometimes we are the ones to make to match the images with the history. So we use MRI whenever there is a discrepancy between the CT findings and the neurological status. And we know now from the literature that MRI is able to show many more lesions than CT, and that MRI, in fact, in diffuse axonal injury, is something that can really help you. And certainly, again, in medical legal cases, it will make a big difference. Secondary lesions. Secondary lesions are those lesions that occur as a result of the injury, usually sometime later, and they include, for example, edema, herniation, anoxia, hypoxia, infarction, infection, hydrocephalus. I'm going to spend a few minutes on looking at these secondary lesions. Brain edema can be devastating. When the surgeons open the skull, sometimes the brain pops out. And our surgeons call this the angry brain. And if they make a craniectomy that is too small, you may actually injure the margins of the brain. How do you recognize edema on CT? Very simple. You see a loss of gray-white matter interface, and you may see actually a downward bowing of the tentorium because of the pressure. So in this case, the cerebellum is normal, and everything up above is filled with edema. If there is a lot of edema, you may develop brain herniations. And the most dangerous one is this descending central transtentorial herniation, sometimes also known as uncal or central transtentorial, where you have compression of the brainstem. And this compression of the brainstem can lead to a secondary brainstem hemorrhage, which is known as a Durette hematoma. And the Durette hematoma is typical a hemorrhage in the posterior to central part of the pons. How does it occur? People believe that there is a pressure supratentorially compressing the brainstem, foreshortening the brainstem, and actually rupturing these small branches from the basilar artery. In Latin, we call it rami ad pontem. So the little penetrating branches that go from the basilar artery into the brainstem, where you have these hematomas. This is something to look for on CT. Here are two examples, two different patients. This patient had a massive subdural hematoma supratentorially, and this, a hemorrhage, and this patient had a massive supratentorial subdural. You see this, and you see this. When you ask neurosurgery residents, and you tell them, what is this? They say, this is blood in the aqueduct. No. This is blood in the fourth ventricle. No. Because you can see the fourth ventricle here, yeah? And it's not the aqueduct. This is blood in the brainstem. And why is this so important? Well, because we know that when you have blood in the brainstem at this location, 75 to 80% of these patients will die. I mean, it's not rocket science. If you have lesions in the pons, you know that this is a very bad prognostic sign. So whenever they bring the patients down from the intensive care, usually after 24 or 48 hours, that is an area always to look for. You focus on the brainstem and you see. And if you see hemorrhage there, you tell the neurosurgeons, and you will tell them that there is a secondary brainstem hemorrhage. Ischemia, or hypoxic ischemic brain damage, is also a frequent occurrence in patients with brain trauma. This is a child brought to the emergency department by the parents. The CT scan looks a little bit funny, but there was a fundoscopy done, and these are retinal hemorrhages. So you think about child abuse, shaken baby, exactly. And this is the MR done on the same day. And just look at the difference. You know, the CT, you're not sure what's happening. You see, you know, you try, and we try always to have a low dose CT, but what's going on here? It's difficult to say. And this is the MR, the same child, the same day. And on the diffusion, you see all of these areas of diffusion restriction indicating diffuse hypoxic ischemic brain damage. In adult patients and in older patients, we often use CT angiography to look for example, for dissection or a disruption of the internal carotid artery. This is a 54-year-old man with speech difficulties, and you can see here that there is one carotid artery missing. And this is the MR performed a few hours later, where you see a number of watershed infarcts at the edge between the middle cerebral artery distribution and the other artery distributions. And we do this quite a lot in trauma patients. Here's another patient, for example, with a stroke, what looks like a stroke. This was shortly after trauma. And here is the CT angiogram. And you will see that there is an obstruction of the internal carotid artery on the right side, leading to this infarct, and these are the reconstructions. So this is actually a dissection of the internal carotid artery. We see dissection quite frequently, and sometimes people may have a dissection just because they are sneezing or coughing. I've seen two cases of doctors who went with their children to an amusement park, and they went on one of these rides, a roller coaster, and they developed a dissection of the internal carotid artery. Now, another type of secondary brain lesion, this is a case that I show you that I like very much. This is a young woman, 18-year-old, who developed deteriorating consciousness. She was the victim of a motor vehicle accident, and it occurred at 5 o'clock in the morning on the night of Friday to Saturday. She had been out with friends. They were going to a disco and to a bar and wherever, and at 5 o'clock in the morning they had a motor vehicle accident, okay? So she was admitted to the emergency ward, and she was treated by the orthopedic surgeons. She had an oblique linear ecchymosis over the jugular region, where she was wearing a seatbelt. She had no head injury, no obvious head injury, and she was neurologically intact, and the fracture was immobilized. Everything was fine. On the Saturday, her parents came to visit her boyfriend, everything was perfectly fine. She had survived the accident, and she was doing perfectly okay. On the Sunday morning, I was on call, which is about 36 hours after the accident. She had a rapid deterioration of consciousness. She was restless, confused, unresponsive. She had emotional outbursts. She had incomprehensible speech. She had the Glasgow coma scale of 11 out of 15, 4 for eye opening, 2 for motor response, 5 for verbal response, and she was transferred to the ICU. Lab results showed mild hypoxemia. Biology screening or toxicology screening was negative. I was surprised because a young woman, 18 years old, in Belgium, having an accident at 5 o'clock in the morning, you are thinking about cocaine, you are thinking about speed, you are thinking about any other things, yeah? Medical imaging, a CT scan of the brain was negative. She had a duplex Doppler sonography that was negative. And they decided to do an MR of the brain, which I show you here, a T1, an axial T2, and an axial diffusion. And we have some more images, T2, and diffusion. So we have areas of diffusion restriction in the thalamus, in the basal ganglia, and also in the white matter. So this is my question to you. What is your diagnosis? Fat embolism. You are sure? Why not diffuse axonal injury? Por la localización. Muy bien. ¿Otro argumento?
Por el cuadro clínico.
¿Por qué?
Por la clínica del paciente.
La clínica del paciente especialmente.
Y la hipoxemia.
Sí, ok. Muy bien. And this is in fact a fat embolism syndrome, and this is the main diagnostic criteria, as you said, is the hypoxia. but it's the deteriorating mental status with a delay of 24 to 48 hours, and then the cutaneous petechia. And this occurs in about 1 to 2% after all long bone fractures. And this was her tibia. She also had some fractures of the thoracic spine. And so how can you make the difference between a cerebral fat embolism syndrome and diffuse axonal injury? Well, both can present as multiple foci of abnormal signal. Arguments against diffuse axonal injury were that there is no neurologic deficit at presentation, which would occur with diffuse axonal injury. There is a central distribution of lesions in white and gray matter. And the arguments in favor of fat embolism are the lesion distribution and also, of course, the multiple bone fractures. So we have to take that into account. And this has been reported as the star field pattern. You have multiple white spots on diffusion restriction and also on susceptibility weighted imaging, multiple spots. This is what is known as a star field, and this is the way that the diffusion looks. So secondary lesions are important in determining long-term outcome. Now, new MR techniques, we have talked about this. One technique that we know is susceptibility weighted imaging. And it's a technique that I love and I hate at the same time. It has changed the way we look at lesions. If we look at a brain like this is a middle-aged brain with some white matter disease. This is a FLAIR image. And if you look at the susceptibility weighted image of the same patient, you see that there are dozens, maybe hundreds, of small punctate areas of hemorrhage. These are so-called microbleeds, microhemorrhages. And these microhemorrhages can occur spontaneously, can occur after trauma. Susceptibility weighted imaging shows more of these lesions than gradient echo T2 star. And I show you side by side a gradient echo T2 star and a susceptibility weighted lesion. Here, if you look carefully, maybe you could see something, but very difficult. From the same data set, there are lesions here, there, and there. And in retrospect, these lesions, maybe you can see on the gradient echo, but the other ones are very difficult to detect. So it makes it easier to see lesions. Another technique that we like is diffusion tensor imaging. And we started maybe 10 years ago with one of my PhD students to look at whole brain diffusion tensor imaging in normal individuals versus individuals after severe head trauma. And you see here that it looks like there are some white matter fibers that are lost, but it's very hard to actually quantify this. What does it mean? So in San Francisco, the group of Dr. Pratik Mukherjee came up with the idea to actually look at the brain and identify a number of white matter tracts and to measure fractional anisotropy and measure actually the fractional anisotropy values in these tracts, and found that in patients with severe head trauma, they found restriction of diffusion in these areas. And they saw changes in fractional anisotropy in these specific areas. And it is now accepted that white matter assessment with quantitative diffusion tensor imaging increases the accuracy of long-term outcome prediction. And we did a little study about this. We looked at 36 whole brain tractography data sets. This has been published meanwhile. And we did MRs on day 7, day 12, and day 180 after injury, comparing diffusion tensor imaging measures. Now, these are some of the patients from our data set. Whole brain diffusion tractography. When you look at these images, it doesn't mean anything. When I show them to you like this, the ones in red are patients who died. The ones in green are patients who survived. What is the difference? Well, if we look at fractional anisotropy of the ones that died, it was on the MR scan on day 12, it was much lower than the survivors. If we look at other metrics, like the number of tracts, it was much lower in those who died than in the survivors. And when we look at the numbers, yeah, the p-values are significant. But when we look, for example, focus on this graph, fractional anisotropy, you see that the lower the fractional anisotropy after the injury, the sooner these patients die. The higher the fractional anisotropy, the more chance they have of surviving and staying alive longer. And there is a group in France led by a neurointensivist, Dr. Puy-Basset, who is using whole brain fractional anisotropy to decide whether to keep comatose patients alive or not. France has a quite liberal euthanasia law, and it is calculated that in France or in Belgium or in Germany or in Austria, the cost to society of keeping one patient who is in a coma alive is about 400,000 to 500,000 euros per year, which is an enormous amount of money. If you look at the fractional anisotropy, you are able to predict actually whether this patient is ever going to wake up from the coma. So there's a lot of controversy about this, whether you can actually use this to decide who lives and who dies, but that's how it's done. So it means that whole brain tractography actually measures patient survival, and the measures are correlated with time till death. So my 8th key point is new imaging techniques allow for quantitative assessment of traumatic brain injury. And we have a project in Europe which is called Center TBI, which is led by the University of Antwerp, Amberes, where I'm from, by our neurosurgeon, and the University of Cambridge, looking at the outcome and trauma effectiveness research in traumatic brain injury. We have a central data registry. The aim is to collect 5,000 patients. We are now at about 3,600 or 3,700. And this was funded by the European Commission to the amount of 30 million euros because they want to have a European-based model for treating patients. These are the participating countries, and there is a similar project going on in the United States. They call it TRACK TBI. TBI stands for Traumatic Brain Injury. Perfusion imaging. Here is a patient who had an injury, and can you identify the coup site? So what did we learn today? To identify the coup site, we look for the soft tissue swelling, we look for the fracture. And there is a fracture here, a non-displaced fracture with a small hemorrhagic contusion on the coup site and a very large hemorrhagic contusion in the frontal area, right? So this patient developed massive intracranial hypertension. Neurosurgeons decided to perform a bilateral craniectomy. This is something that 20 years ago in my center and in Europe nobody was doing, but now we are doing this quite often. So a bilateral craniectomy, allowing the brain to bulge out on both sides. And when you look at the volumetric reconstruction of the CT, that's what it looks like. Bilateral craniectomy, the brain is bulging out, yeah. Now, the thing is, what about the brain? What is the quality of the brain? So let's take a look here on this perfusion scan with the perfusion maps. And we see that, of course, there is no perfusion in the frontal area where there are hemorrhagic contusions, but there is normal perfusion, or more or less normal perfusion, in the occipital lobes, in the temporal lobes, in the parietal lobes, so the other parts of the brain. And some people believe, including our neurosurgeons, that cerebral perfusion may become a useful determinant to actually decide for long-term outcome. You can get an idea of how much of the brain is still perfused. Last point, and my time is almost up, long-term sequelae. We know that when the brain is damaged, you have this brownish, reddish discoloration indicating hemosiderin. And this is an area of tissue loss, and the correct name for this is post-traumatic encephalomalacia, encephalomalacia for the British. Here is a patient with a frontal trauma with a depressed skull fracture, and this is the MR 3 years later. And you see that there's an area of tissue loss indicating encephalomalacia. Now, if you look at the axial images, we see that there is tissue loss surrounded by gliosis, of course. And then when you look at the gradient echo, there is hemosiderin only on the right side and not on the left side. Why is that? Well, if you go back to the original CT scan, 3 years earlier, you saw that on the right side, there was a hemorrhagic contusion, and that leaves hemosiderin. And on the left side, the contusion was mainly non-hemorrhagic, and there is no hemosiderin deposition in this area. So for detection of long-term sequelae, MR is the preferred technique, and brain trauma is a life sentence. Final thoughts. I think we are very good with imaging to predicting the future. We are the eyes of the neurosurgeon. Never forget that, but also be available clinically to the neurosurgeons. Second, if we want to do imaging to be a biomarker, like fractional anisotropy or diffusion-weighted imaging or whatever, we need to move beyond a qualitative description and move towards quantitative. We have to quantitate hematomas. How big is the hematoma? How much is the mass effect? We'll talk about that tomorrow. And finally, it is very important to standardize data collection and data analysis. This is a very big challenge, because what you do on your machine, which could be a Philips or a Siemens or a GE or whatever, may be different from what I do on my machine with the sequences, and it's very difficult to compare these values. So with this, I would like to thank you very much for your time and attention. It was an honor and a pleasure to be here. Thank you very much.